Welcome everybody. Thank you for joining us for this live stream with the Practice Index team. And today I'm really happy to be joined by Robin from Bristol, who's one of the practice managers from the Practice Index team. And this is your opportunity to grill me. So we're going to see how this goes. How are we doing, Robin?
Not too bad, thank you. Got quite a few interesting questions for you, some of them which may come across as a bit controversial, so I hope you're ready.
I'm definitely ready. So first of all, thank you to the Practice Index team for joining us for this kind of event. Effectively, we discussed about what would be a great thing to help provide for practice managers and supporting them. And I kind of said, well, they kind of came back to me saying we'd love to ask a GP questions, but we just still can't seem to ask other people. So I was like, all right, fine, let's go for it. Let's go, quiz me, grill me, whatever you want to do. So this has been your opportunity to ask questions to a GP, and I'll try my best to answer them. I guess slight declaration, clearly I can't answer for the entire general practice. I'm not planning on doing that. And although I have various different hats, I'm not speaking from any of those particular hats. This is my own opinions and views and that kind of stuff. And just a bit of a declaration of a GP partner, clinical director, national rep to RCGP, and a few other things like LMC rep and stuff. And I'm also a tech geek, as many of you probably know. But yeah, Robin, you're from which practice was it again in Bristol?
Kingswood Health Centre in Bristol.
Cool. And I know you've got a variety of questions that we've already had pre-submitted. However, if anybody does want to ask additional stuff, let us know. Just put it in the chat and we'll bring that on and be able to answer those questions best as we can. Shall we get cracking and see how we go from there?
Let's go for it.
So,
okay. The first one that we were asked is, are GPs actually as busy as they always tell us they are?
I would say absolutely. So clearly I'm a little bit biased here, being a GP. I think one of the things that is easy to tell is if you have a look at our appointment books and that kind of stuff, you can clearly see how many appointments and things we've got booked in. The question of, does that mean we're actually doing stuff? Yeah. I think most practice managers will know that a lot of the times that just because we may not have a patient physically in with us, and clearly not over the past few months as much as we would have done prior to that, that we're always trying to do other things, and there's inevitably various other things that come into play. Just like you see, patient contact stuff is not the only thing we're doing. There's the clinical admin, there's the organizational stuff, there's audits and that kind of stuff that happens as well. I think maybe there's something to be said about productivity sometimes and how we structure our days and that kind of stuff. And I know that's something I often talk about. And could that be better potentially for some places and for some teams and that kind of stuff? Yeah, but I think, let's put it this way. I know from the moment I walk into the practice to the moment I leave, I'm pretty much always doing something. And yeah, it's always busy. But I'd be keen to know if that's the view that PMs have of us, to be honest, because I gathering that may not be the case.
I think it generally is. I think we appreciate that if you don't have a patient in front of you, it doesn't mean that you're sat there just waiting for the next one to arrive. And there are so much other things that need to be done. But I think there's been a lot of focus over recent years of what practices can do to reduce the admin workload, especially on GPs. Yeah. And with that going down, are you finding then that you are having more free time, or actually are you just filling it up with other stuff that you weren't getting around to before?
I think it's probably the latter. I think one of the key things to remember is that the complexity of the type of work that we are now dealing with is significantly increasing. If you go back 15 years or so, most patients consulted about one healthcare issue at a time, and that was all that they had to deal with. Clearly now, as time has progressed and we learn more about conditions, there's more treatments available, there's more things to consider as well. We've learned more obviously about health and medicine, and life has changed as well. It's bringing new challenges. I mean, cyberchondria was never an issue 15 years ago. Now it's a constant issue that many of us have to deal with. So there's other elements at play, and trying to deal with all that. Yes, the admin may hopefully be going down a little bit, but that complexity is actually significantly increasing outwards, more than what we're coping with. And everybody feels that, and the practice team feel that, the reception, I'm not sure, feeling that, the practice managers are feeling that demand is just, it's doing this right now. I don't know if that's the right way for everybody else, but for me it looks okay. And our capacity just doesn't fit with that. So it's trying to figure out how you can use the resource you have most effectively for the reason, or as I like to put it, the right person seeing the right patient at the right time. That's the key thing.
Fab. Okay, you ready for the next one?
Let's go for it.
Okay, so how do you prioritise what comes in? And that this person kind of expanded by saying sometimes they don't get the answer they expect when they've chased you up for something.
Yeah, I think that's an interesting one because it does depend what it is. So if it's a patient needing an assessment, I think there's trying to balance the whole concept of, okay, what's the individual things for that patient that plays in part with it? What's the resources I've got available to make me understand how I can deal with that situation, and my own clinical knowledge that will have an impact in terms of what I'm comfortable with. And I think that's one of the things that probably people often see, and it's the beauty, and it's also the challenge of general practice, that everyone's got a different viewpoint. You're never going to have the same person giving the same answer. And what I would see from having an interaction with a patient may be completely different to what one of my colleagues would do because of their training, their understanding, all that kind of stuff. So therefore, what comes out of that may be completely different. So as an example, I've been telephone consulting for many years now. My confidence with being able to assess a patient over telephone consultation is probably more than some of our colleagues that have only just started doing telephone consultation. So, my ability, I think, to get certain piece of information, make me feel reassured about what I need to do with the patient. And that's going to lead to a different outcome, isn't it? I may say to a patient, I'm more than happy to deal with this over the phone, or actually, you don't need to worry about this. Potentially, one of my colleagues may say, actually, I still need to see you face to face and we need to do this. Or, I think what you've said is treatment A and I may come out with treatment B. So it's just, yeah, it's difficult in terms of prioritizing it. My key thing is always, if I need to see somebody, or I need to have a physical interaction with that person, I want to try and make sure that's the thing that happens first. It's always trying to find where the block is, where's that rate limiting step, because that's the thing that's going to inhibit me doing all the other stuff. So if it's assessing a patient, if I've got a little piece of information that says, okay, I might need to see that patient face to face, or I've got another patient with something that less likely to. So really good example. If on my triage list I've got a patient that has, the pre-information is they've got difficulty breathing, they've got issues in terms of how they can move around and all that kind of stuff, they're more likely to need a face-to-face appointment than somebody coming to where the pre-information is they've got itchy skin and they want to talk about their creams. That's an easy one. The latter one's going to be lower down on that list. The more complicated things are obviously when it's individual patients that you know really well, and they present with some things that don't seem obvious, but once you go into it, clearly that changes the outcome. And there's numerous examples of that I won't go into. But prioritizing, it's what's the next step for me and how is that going to limit the services I've got.
Fab. Okay. And sort of following on from that, how often do you disagree with a clinical decision made by another GP?
Less than I used to. Let's put it that way. And the reason for that is over time, we've got increasingly more and more guidance to help us understand how to manage various different things. So, I mean, I think part of the challenge we've now got is got so much guidance that it's really difficult to figure out which one you should be following and not following and that kind of stuff. But as I mentioned earlier, one thing to remember that every clinician has got a different basis in terms of their training, in terms of their personal experiences, and also the information they may establish from their interaction with the patient. So what they interpret from what the patient said and how they've done it, and that's part of the art of medicine. I guess that's a key thing. Medicine is an art. We try and simplify it and say it's a science, but it's not. It's about communication. It's about understanding what the patient's objective is. I mean, as a trainer, one of the things I teach to a lot of my trainees, what the patient may feel as a symptom, before you even understand what that is, they have to understand what that is to them. They have to be able to communicate it to you. You have to be able to receive that information. Then you have to relate that to what that means to you and then process it back and forth. And there's so many ways that can go wrong, to be honest. As an example, a patient feeling nausea may be a different feeling from one patient to another. So is that nausea with retching? Is that nausea where they're actually vomiting? Is that just a feeling of queasiness? Or, that can mean so many different things. When they've explained that to you, you may interpret that as something completely differently. And it's just trying to understand that element of change that happens. And that's why people often may prescribe things differently. The guidance helps because nowadays we have so much guidance to say, like how to manage blood pressure, high blood pressure. There's really good, clear-cut guidance on how to do that. So that should work. Most places have their own, for example, antibiotic guidance and certain things you should be considering or looking for if you're thinking it is bacterial versus viral infection. So that really helps. And we have risk scores as well to help us. The question of, if I don't agree with a treatment, well, I'd want to understand why I'm not agreeing with it. And it may just be that, we've got different preferences. So there's so many, for example, different types of creams out there. Some people prefer one type of cream, some people prefer another, just because of the experience they've had with using that with patients and how patients engage with it, and their own personal experience as well. The only time I really get concerned is if it's something that it just seems like a massive, I really, really don't understand why that happened. And I think the only way to get around that is communication, is understanding why that's been the case, talking to the person, and also having that in the notes. So I know sometimes I will do things that may not seem obvious, I may not follow guidance, but when I do that, I try and make sure that I've been as thorough in the notes to explain this is the reason why I've taken this choice for this patient, because for them, that's actually the better option based on the information I've got. Does that help?
Yeah, I think that's good. Okay. This is a bit of a mammoth question. If you were the health secretary, what would you do in primary care?
I'd give primary care a lot more money. Let's put it that way. So it's no, well, there's no mistake about this. Primary care does 90% of the workload of the NHS, and we have less than 9% of their total budget. Some of that is being equalised, and if you're asking a workforce to deliver that volume of work and giving them such limited resources to do it, it's going to be hard. It's going to be difficult. I think the other thing I would really focus on is a public health campaign to help patients understand what healthcare actually means in this country, because I think many people don't. I think many clinicians don't, to be honest. And we're going to see this become even more complicated over the coming years with things like PCNs and additional roles and all that kind of stuff. I'm a clinical director, and even I don't have a complete 100% handle of what all the various different roles can do, how they can work together, and how they can help patients and practices work effectively, because there's so many different, we've got 10 new additional roles that are being supported and funded, and then you've got adaptations of those roles as well, and then it's so complicated. And if it's complicating for us, imagine what it must be like for the patient, who their model of understanding has always been doctor, nurse, reception. Yeah, that's pretty much all they've known in general practice, and now they've got reception, clinical navigator, social link prescriber, health and wellbeing coaches. They've got nurses, of which there's about 4 or 5 different types of nurses, physicians associates, pharmacists. There's like 3 or 4 different types of pharmacists now, and then GPs, obviously, different types of GPs, different specialisms in general practice. And there's even more roles. Physiotherapists are coming in play, mental health workers are coming in play. It's confusing. So an absolute clear cut, this is what the healthcare system is. This is the time that you can use as a more, helping patients understand that, so that they can try and navigate to the right part of the health system a bit more effectively. And I know this is going to be slightly controversial. I would even consider start charging for certain aspects of the healthcare system, because I think one of the things that general practice has really struggled with is the capitation model. And I think I completely believe with the point of access, but you can't have unlimited access to something that is completely limited. That needs to be dealt with.
What kind of things do you think would be reasonable to charge for that we currently do for free?
I think prescriptions needs a massive overhaul, if I'm being absolutely honest. The prescription system that we have has not had any form of reform for many years, and there's certain elements that they just do not make sense to me. I do not understand why a patient with one health condition that doesn't have an overriding impact on the various other elements of things. So I'm sure I'm going to get people shouting at me for this one. But for example, if you have hypothyroidism, and require medication, which you do require and is essential that you have to make sure your health doesn't deteriorate, you get all your medications free for life. Whereas if you have COPD, a health condition, that affects the lungs and stuff, you are not eligible for free prescriptions for that, despite the fact that that condition can, if it's not treated effectively, lead, worst case scenario, to death within within minutes in certain situations and stuff. And therefore we have patients that don't follow their treatment effectively because sometimes they just cannot afford their medications. That doesn't work in my head. That's not sensible. So, I think the prescription system definitely needs a reform. Does that mean that we charge for all prescriptions? Does that mean we charge for prescriptions, medications that you can get over the counter and not have those available to those for free on the NHS in other routes? Or do we not charge at all for prescriptions? That is a discussion we need to have. At the very least, I personally believe in the healthcare system, because it doesn't work right now at all.
Interesting stuff. Okay.
Yeah, I'm sure I'm going to get some comments on that one.
Okay. Well, you can see already that you're a GP that loves his IT. So what is the useful technology tip that you suggest we can pass on to our GPs? And I'm just going to add a little caveat. What about the GPs who aren't so technologically able as you might be?
Okay. So I think it does depend on the type of role that you're looking at and where you're starting from. But I think if you're looking for something universal for all clinicians to be better at doing, and that's just simply putting information into the systems that you use. So if you wanted something that will help you save time and help you with stress elements, just look at how you're putting information into the system. And that can be done by various different ways, whether that's using template systems to try and help you. So things like Ardens, primary care IT, that kind of stuff, to just streamline the way you put information into the records. Is it learning to type quicker? In my view, that is one of the best productivity hacks that any clinician can do. If you can increase your typing speed, you will actually increase your productivity significantly in every part of everything that you're doing. And for those that find typing just too much of a challenge, we'll then look at things like dictation systems that can help you speed up, so that you can hopefully put that information into the records a lot quicker, because that's where you're going to save real time. It may not sound fancy and sexy and all that kind of stuff in terms of a big change, but that's the one that's going to potentially make the biggest impact in how you do things. And that's even going as simple as the comfort of typing. One of my bugbears that we have is that in the NHS, we use stock kind of keyboards. Everyone has the same keyboard. Traditionally, it's Dell. It may be something like that. But actually, is that the best kind of way for you to put information into the computer, considering that most of us spend 90% of our workday on the keyboard, and we have the most, to be honest, bargain basement carbon copy piece of kit that may not be comfortable for you, may not be effective for you, may be more resisting? What about using things like shortcuts? Keyboard shortcuts definitely will help with that kind of stuff, and just improving your comfort. We spend so much time on these devices. I'll show you mine. That's mine. That's the one I use. So yeah, fair enough. I'm not saying everybody goes out and gets a big fancy keyboard like this. It don't have to, but just looking at, is it comfortable for you? Is it the right spacing, height, all that kind of stuff? And is there certain things you can learn about using it that can speed up your time?
Brilliant. And then in this similar vein, what useful tech tips do you have for us practice managers?
So everything I just said will definitely help. So inputting information quicker. PM spends so much time, again, on a computer. So anything that you can do to speed up the input time. I guess things that potentially, from my perspective, may help with the practice manager's time is figuring out a communication system that works within the practice. Because I can guarantee you, one bugbear for almost every practice manager will have is that they never get their GPs to respond when they want them to. Am I wrong there?
No, I agree with you to some extent. I think for us, it's communication with everybody, because we're the centre almost of the practice for all staff. Yeah. So it's making sure you've got communication right to all areas is going to help. But it's trying to manage all of those different preferences. Some people would rather you pick up the phone. Some people would say send me an email. Some would say send me a screen message, and then trying to have all of that in your head. And if you're a large practice managing 50, 60 staff, it's just trying to remember which preference goes with who.
Yeah, agree. And that's a challenge, and everyone's going to have their own preferences. But I think one of the key ways that can work within a practice is ideally trying to get everybody onto one system of communication for the majority of stuff. So I know a lot of practices default that to being email. Email is okay. The important thing to remember, though, email as a discussion tool is awful. It is horrific. It is not designed to be used as a discussion tool. So trying to use it in that mechanism just means that you get less engagement and stuff. It's great for notification based stuff, for just sending information, here, take this away, or potentially, I know a lot of people use it as a reminder mechanism and a storage mechanism, but as a discussion tool, it's awful. Don't use it for that. I think Teams is going to change the way that we work massively. MS Teams, and particularly the universal access that we're going to have, is going to significantly give the opportunity to streamline practices. The question of whether practices will be able to engage with that, well, I'd probably suggest taking the bull by the horns and going for it. Get everybody on board, get everybody thinking this is the place where we need to look for all of our information and stuff. And actually, if you can do that, you may find a lot of this works a lot more effectively because it's everything in one ecosystem. Things to remember about Teams is not the best tool at doing each individual bit, but it is the best tool that we have in the NHS for doing everything. And that's the distinction.
Yeah, I think since COVID, having to use video calls, even when you're in building as your other staff, just because you can't have too many of you in one room, has really forced people into using that kind of software. And people have just got used to it and find it really helpful. And I think, where I'm at the moment, a lot of people are still saying, are we ever going to go back to face-to-face meetings? Because why would we need to?
Yeah, I mean, I'd be suggesting that we probably need to think about going back to what we call hybrid meetings. So where you've got an element of face-to-face as well as the remote aspect for those that can't physically be there for whatever reason that may be, whether that's down to health issues, whether that's just simply down to time. So recently, the other week, I ended up having to jump between Teams meetings because I was actually in 2 meetings at the same time. Wouldn't be able to do that normally, would I? But I had the opportunity to do it. It was okay. It takes a bit of work, to be honest. It takes a bit of practice, but I was able to participate in both meetings, get my training from one, and engage with the patient MDT meeting for the other at the relevant times. It works. It's just structure.
Cool. Okay. And so, what is then your favourite piece of IT kit?
That's easy. It's my phone. Yeah, so my life lives off the phone, and I don't mean that in a addicted way, although I probably am addicted, let's be honest. But the productivity I get from being able to use my phone is quite significant, because it's a mobile device that allows me to be connected to everything else I need to do. I don't hide the fact I do have about 10 different hats and stuff, and all of them can be worked through that. It was really interesting at the beginning of the year. I lost my phone and I had to go without it for 3 days. And that was pain that I cannot imagine going to go through again. But you know what? It survived. It was fine. Honestly.
Was it fine? Are we still like PTSD about it?
A little bit, Well, one of the amazing things about technology is everything can be backed up and you can access it wherever you need to. So, I always advocate that people, when they use systems, make sure you've got resilience within them to figure out what happens. So, for me, one of my best software pieces of kit that I use is a password manager. And I advocate this to anybody working within the health system. Use a password manager, secure one, to keep an eye of all that stuff that we have to do. Because let's face it, in the healthcare system, we have numerous logins, more than we would ever care to accept. And the requirements for those kind of passwords is just draconian at times. Rightly so, let's be honest. But at the same time, it can, I have one system where the password limit can only be 6 characters. You can't have more than 6 characters. And that just seems weird to me. It's completely different to every other system that I have to use. So trying to keep an idea of what that password is and the stress it causes when it doesn't work is, it's annoying, isn't it?
Yeah.
So yeah, having a password manager just helps with my stress levels, to be honest. I keep everything backed up on there. It's remotely accessible. I only have to actually remember one master password, out of which, to be honest, through my phone I can access it through my thumbprint, which theoretically nobody else can copy. And I can also add in 2-factor authentication for when I use it online. So just like with banking, I'll get a text message say, can you confirm the code, so I know that it's secure. And I can access it wherever I need to and whenever I need to, as long as I've got an internet connection, which, to be honest, I'm only going to access them when I've got an internet connection. So, yeah, it works.
Then that it make it hard to switch off from work to have everything coming through your phone.
It can do. So having things in place again to help with that is really important, and looking at good digital health use. So I've various things on my phone, like for example, my phone goes black and white at 10:30 in the evening. So that's kind of like a a reminder that actually I need to kind of get off the device. And when there's no color, you kind of don't like watching Netflix and stuff as much, do you? And things. And yeah, don't get me wrong, I get it wrong at times. My wife will definitely testify to that. But trying to have rules about no devices at particular times of the day, making sure that people can only contact you in particular ways. Information travel is a real challenge in general practice. I talked about the fact that once I sat down with a piece of paper and wrote down the various different ways that people can contact me in my role as a GP. So this doesn't include my network roles and all the other kind of stuff. One per line. I was on 2 sides of A4, double-sided, and I was still going. So when you include things like tasks, notifications, clinical systems versus email versus WhatsApp versus Teams versus every other kind of network that goes, I've never hidden the fact that I'm on about 7 different social media channels as well, of which some of them I've got multiple profiles for. There's just so many different ways information can come through to you. So it's making sure that information comes through to you in the most effective way to you. So, in actual fact, only a few people have my phone number. So I know that if somebody rings me, it's somebody really important. Whereas, if they message me, if they WhatsApp me, actually a lot of that I engage with when I want to, because I intentionally switch off the notifications for most of those groups, and I'll just jump in when I want to, not when somebody else wants me to.
Yeah, very sensible. Okay. So one of the things that we often get asked, actually, what item of equipment or anything would you like for your practice, but you just can't justify it?
Okay, so if we talk about for my practice, the butterfly ultrasound device.
What is that?
So this is something I think that potentially healthcare could look at a bit more effectively. There's a new type of ultrasound device that is portable, fairly cheap in comparison to most ultrasound devices, and allows clinicians to have a much better imaging of various different things, like the heart, like the lungs, that kind of. It's basically like a portable ultrasound device, but much more cost effective than the kind of run-of-the-mill ones, and it can work with any mobile device. So you just plug it into a phone and you've got yourself an ultrasound, and that can have, from my tech kind of geekiness, being able to use that with a patient, because it's more available at that kind of price point that you could have it per clinician. It's something like about £2,000 per device, which I know sounds like a lot of money, but if you created a specific service around that and had a clinician trained with it, it could work really well for patients, and in terms of services that you can offer within your practice compared to having to outsource them to other departments and that kind of stuff. So that's one I would definitely consider. If I was just simply looking at general health and well-being and all that kind of stuff within the practice and productivity, standing desks for all staff. Absolutely, that would be the one. I've never hidden the fact I'm a big fan of standing desks. I'm using one right now, in fact. So just to prove a point, and off we go again. Yeah, but productivity, health, well-being, massive thing for me in terms of being able to have my. I would not go back. In fact, I hate it when my room dies and I have to go to another room and sit down all the time. Absolutely hate it. So, and doing that for all of our staff, actually, we need to look after the health and well-being of people. It's something that can have a real impact.
Yeah, I've got one as well, and I used to work in secondary care before becoming a practice manager, specialising in HR, and the amount of musculoskeletal absence from work is the second highest cause of absence from work is due to poor posture and bad backs and bad pain. So, and having used one myself, it is definitely revolutionary, I think, in how it in terms of working and supporting your own spine, but also in productivity as well.
Yep.
Yeah, love it. Good idea.
Absolutely, and I even use it for patients as well. I know some people kind of frown their eyes at that and think, okay, how can you do that? But you know what? I practice what I preach. I say to my patients, look, this is what I'm doing to look after my health. Is this something you need to consider in terms of your health, in terms of, not necessarily you having a standing desk, because that may not be appropriate for them, but looking at the adaptations you make within your life to look after your health and well-being. You can't just do things because that's what people do. You need to be able to do things that work effectively.
Definitely. Okay. So which of the roles covered by the new additional roles reimbursement scheme, that's a lovely mouthful, are you most about, and why?
So for me, it's got to be the mental health workers, the first contact version of that. I work in an inner city area of Nottingham, significant amounts of deprivation and mental health illnesses, especially. Having access to that particular role, I think, will be a real impact in terms of the service to our patients and help and well-being for our clinicians as well, because they're a challenging consultation to have to deal with on a regular basis. And let's be honest, right now, we're dealing with a lot of them. Post COVID, we're seeing so many issues in terms of mental health, both low level and high level, and those patients that are fluctuating in between. And having that support and that mechanism to help us deal with some of that emotional workload, I think will be a real benefit to individual practices, to network areas, but also to our clinicians. I think it's important to recognise each of the roles has potential to be really effective, but it is also very much based on your area, what's going to work best for your patients and your area. No one role is going to be revolutionary to everything. I know many people talk about the benefit of pharmacists, and there is an absolute benefit to having pharmacists, and that's obviously the one that's being pushed quite heavily at the start. But that's also because that's the one with probably the most capacity as well. So there are other reasons for that, and taking that element of workload away from GPs is really sensible, because let's be honest, pharmacists are so much better at medications than GPs are. I will easily say that. I've been working with a pharmacist in our practice for 3-4 years now. Man dwarfs me when it comes to medication knowledge. I don't know how he fits all that into his brain. And that's where safety and quality and all that kind of stuff come into play. But it's just trying to figure out how that works best for the patients, how that works best for the area, and how that works in terms of funding as well.
I think it's difficult, isn't it? Because I don't think there's an area of the country where access to mental health support is good. So everyone is going to be clamoring for these roles when they're available next year. And because of COVID, we now got the need for them as well. So I think there's going to be a lot of work coming up in how we're going to make this work without destabilizing the existing services for mental health at the same time.
Yeah, I definitely agree. I think it's going to be a real challenge. I mean, many people also recognize, if you're talking about a button fight for roles, the paramedic role is going to be the one which was obviously delayed till April as well, just because of the absolute recognition. If networks all go out and try and hire paramedics, and that's going to leave the paramedic services with nobody. And then we're going to have a real problem across the country in terms of staffing of that service. But what do you do? I think that's probably where some of these roles need to be considered about what the plan was 2 years ago and what the plan needs to be now. Needs changing. Definitely needs changing and needs considering. And maybe we'll have some more details about that soon.
Which kind of leads nicely into the next question, which is, what are your views on primary care networks as a whole?
So clearly, again, I'm going to point out my slight conflict of interest or declaration of interest here, that I'm a clinical director of a primary care network. So I definitely sign up to the values I think that the primary care networks can offer. I think it's also a challenge. And I think, there is this element of, is it going to fix general practice? No. It's not designed to. It's designed to try and offer, in my view, better healthcare to the populations, and the hope is by offering better healthcare to the population, that has a knock-on impact in terms of what that does to practices and the challenges that practices face. We've had many different changes to the healthcare system over the years. Many people thought that the introduction of CCGs would give power to GPs in terms of being able to determine local healthcare. It didn't. It had GPs on positions of, where they had an impact to decide what happens, but there was still the recognition that they had to stick to the requirements of the funding and all the other asks of the host organization, the CCG, which ultimately were tasked with making sure that healthcare is provided within an envelope of a budget. So in terms of how that works with networks, I think, there are some parts and some elements of working within a network that are really important and really valuable, and I think will have an impact with practices. But that only works if everything else is working effectively as well. So we have massive issues with estates, huge problems with primary care estates that is really limiting what we can do. And if they're not fixed, to be honest, there's no point giving us loads of possibilities of funding for additional roles if we've got nowhere to put them, So that needs definitely a consideration of how that's going to work and work effectively. I've never hidden the fact that my practice is one of those practices having significant interesting issues with NHS property services and the finance side of things. Like many practices, we have real challenges, but I can't put people in my rooms because I just cannot afford to use those rooms as they are now, let alone have more. So how is that going to work for our patients? Because again, we're hearing more and more patients want to be seen, not have access, which is a different thing. And then I think there's that whole element of, are we blurring ourselves into public health versus population health versus primary care? And I don't think many people understand the difference between the three, to be honest, because they are becoming blurred. But how is that going to work over time? How is that going to work in terms of delivering effective care? I think, like I said, I do sign up to the principles of what a network can do. I do think the funding model is still not as good as it could be. I think it's as good as they've been able to make it in some ways. And I think there is definitely some things that could be changed about it to make it work more effectively. But absolutely, other parts of the system also need to recognise that they need to step up and help. Otherwise, it's just not going to work. Is that good enough?
Yeah. No, I agree with you. I mean, the estates issue as well. It's nice to hear that it's on the radar of the clinical directors and the GPs as well, because a lot of practices, even in my area, are all excited about these roles. But the question is, where do we put them? We're all maxed out.
Yeah, and I think the other one as well is the absolute question of the responsibility of the employment. This whole concept of having a lead employer in the first couple of years was not really a big problem for many people. As we move into year 3, year 4, and year 5, where funding means that you're going to have a sizable workforce, who's going to hold the responsibility of those employees and the management? And because unfortunately all those costs are just not factored into it. There's the funding for the individual, there's not the funding for the management of that role, because the amount that we get to manage the network doesn't cover it at all. Not if we're being asked to do all the other things as well. If we weren't being asked to do everything else on top of that, actually would, but we're not. As usual, we're being asked to eke out every part of a penny to the pound kind of thing. I think it's going to be interesting. I know there's various different places that this is going to be discussed, and I'm going to give a really slight promo to this. So next week on Wednesday, I'm facilitating the Digital Primary Care Conference, where we've got a virtual conference where hopefully a lot of this is going to be discussed, and the opportunities for many practices to engage with digital first providers who are supporting some of this, but also the opportunity to ask Nikki Kanani some of these questions as well, because she's going to be presenting the future of general practice at that event. So if people do want to come join us, have a look, come join us.
Wow, cool. Okay, so moving on to more recent times then, what do you think has been the biggest challenge that we've faced as a result of COVID?
Communication. I think communication has been the absolute biggest challenge that we've faced in various forums. So communication within practice has rapidly changed. As you mentioned, the way that we now talk to each other is completely different. Many people used to meet around for a huddle, and they can't do that in the same way. It could be done in some places, and some places they've had to resort to teleconferencing to have their huddles, and losing the personal touch that comes with that. We're losing our ability to meet as a team properly, even outside of work. So, I hate to say it, Christmas is coming up, but we're not going to be having many Christmas parties and stuff, are we? And that's normally seen as a real morale booster for primary care. The opportunity to get the team around. Many places have not been able to have the opportunity to go out and just team building in the same way. It has to happen in a different way. And then there's also communication overload. I mean, guidance was changing on an hourly basis at the start of this, wasn't it? And I cannot imagine how practice managers coped with that, to be honest. I'm fortunate I've got an amazing practice manager that was just on the ball and was telling us what we needed to know, how to do it, trying to coordinate us, delegating, doing everything. And it was still too much, let's be honest. Everyone was just frazzled, and still are, by the amount of changes that's coming through. Okay, some of that has to happen because the stuff was changing. We were dealing with a once in a generation situation, hopefully. But trying to communicate that within the systems really needs to be a consideration, I think, across the board. And then finally, communication with patients. How do we talk to our patients? How do we help them understand what we need to do? How do we keep them informed? one of my pet projects has always been about onboarding patients. Something I'm really keen that we look at more effectively, helping patients to understand how to use the healthcare system, how to use our parts of the healthcare system effectively. Because if you can do that, the friction just melts away. It becomes so much easier. So recognizing that not everybody knows the difference between A&E and general practice and urgent care centres and that kind of stuff. Not everybody knows how to even request their own medications. Common friction point for many patients. Actually, if you help them understand the options that they have and which one works best for them, you can reduce so much friction and less stress with patients and stuff. So how do we communicate that with patients? How do we communicate when we have to make changes because we are told we have to make changes, and we have to make them with patients effectively so that then they understand why things have changed? So as an example, my practice temporarily had to move site during the height of the COVID period because our building was being used as a clinical management centre for seeing high risk COVID patients. So we couldn't see patients in our building. We had to signpost them to another building. So we weren't shut. We were just having to see them in a different site for a few weeks. And how did we communicate that? Well, we used every option that we had. When we spoke to patients on the phone, we told them that you have to go to this site. We'd sent them a text message to help remind them that they have to go to somewhere else when they're being seen face to face. We put it on our social media platforms. We sent out messages every time we had a telephone contact with the patient, because that needs to permeate deeper. We even approached the local media networks and said, look, can you give us a hand with this to try and figure out how that's going to work? Because communication is key.
I think one of the biggest challenges that we've as managers has felt is that there's a big gap in the communication between the government and the NHS. So it's lately, especially, that the media find out things before we do. And then we have patients who are phoning us up and saying, I'm 52 with no other health condition, but where's my flu jab? Or I think I'm a shielding patient, but I've not had a letter. Where's that letter coming from? And those are some of the biggest challenges administratively, I think, on our behalf. It's just the lack of communication between the government to us before it got to the general public.
Absolutely. I mean, there was obviously that infamous letter that came out a couple of weeks ago, that has caused so much, I keep using the word, friction between, how general practice feels and the rest of the entire healthcare system and NHS England and that kind of stuff. And let's be honest, majority of that was down to an error in communication. If you look at the letter itself, the content of the letter, it's not actually that bad. What made it so bad was the fact that the media got a handle of that letter well before primary care did, and they got to create the narrative. They got to create their own, communication on what that meant, and that's what caused absolutely the key problems that we then faced as a result of it. And problems with patients saying that they should have various things when actually we were doing that well before. I understand there's been recent stuff that's come out that showed that the week before that letter came out, that the number of face-to-face contacts was rising exponentially even before that letter came out. So, not to say that that letter's caused that rise, it didn't. And the reality that actually that letter was designed for a very small minority of practices, but it made the entire general practice feel like it's being battered over the head. And that is purely down to errors in communication, in my view.
Definitely. And if I could do a little plug for Practice Index while I'm here, some tools out for those practice managers who are watching on how you can respond to patients' views that you may not have been open. There's a lovely bit of text that you can copy and paste, put your own stats in, and it just responds to those people who think that we've not been doing what we have been doing all the way through. Okay. So the next question we've had is, why don't GPs offer more practice managers the chance to be partners when they bring so much value to the business?
I think they should. Absolutely. So you're not going to get an argument from me. I've worked in practices where they've had practice managers and non-clinical partners. And I think that it's important to remember it's the person that you are having as a partner. It's not necessarily the role. The role has complications, so I will put that rider with that. So it's important to remember that general practice doesn't work like partnerships like most people understand them to do in terms of business and stuff. We're not limited liability companies. The responsibility lies with the partners, and that brings an element of responsibility. I know some people sometimes say that you need to understand the clinical element of that to understand the responsibility. I don't really sign up to that belief, if I'm being honest, because I think it's the person that you're having involved in that and what they bring to the role. So to be honest, I feel most partnerships should have a practice manager or somebody with a business sense. Let's be honest, that's the key thing involved in the partnership. Because I've also seen partnerships where it's been people that felt partnership is just a matter of progression of their career, and they may not have actually had the appropriate skills to understand partnership as a whole and what that means. And the key point is that general practice at the end of the day is a small to medium business. Okay, now we've got the super practices which have kind of changed some of that model, but it is a business. It's trying to understand what needs to go in, what needs to go out, how to manage it, all that kind of stuff. And that cannot only be clinically led. It has to be led from the viewpoint of balancing the clinical with the organizational and with the financial as well, to make sure it's viable and that you keep running. Because if you're not, then that's not good, is it, to be honest? So I think practice managers should definitely have the opportunity to be partners, just like actually I believe nurses and some of the other roles as well have that, because it's the person that you want and the skills that person brings to the partnership that's important. What does need to be worked out is how that is made equal. Not just from a financial perspective, but from a responsibility perspective. And I know different places have different ways that they do that. Some do it based on time, some do it based on shares, some places do it just with other weird figure. I still can't quite figure out. But it just needs to be equal, and it needs to be sensible. And if you do that, you've generally got a better option.
So what did you think when the new to partnership scheme came out this year and it actually excluded practice managers over clinical roles that you might not even normally see in general practice?
I think it was a massive oversight, and it shouldn't have happened. I think, like I said, it is down to the person that you are trying to bring into the practice and the expertise that they bring, not the fact that they're just a clinician. And I know some people will say no, that absolutely has to be a clinician. I don't agree with that at all. I think it's what that person brings to the partnership that's the most important thing. I would much rather have somebody that has absolute financial sense and can deal with that element of stuff and organizational stuff than someone that is really good clinically but doesn't see that as an important thing as a partner, because actually you need to have both. And if you don't have an appreciation of both, that's where you get stuck. And many times general practice are offered to take on things, and the emphasis is, oh, this sounds really good for the patient and general practice is best placed to deliver this. But actually, are we? Is that the best option for all of our patients? That's the key thing. We often deliver services for individual patient groups, and that's really important, and that's really useful, and that's really helpful, and that does have to happen. But if that's also negatively impacting all your other patients, is that actually the best thing? And great example of that, leses sometimes. So, they can sound really good, really effective. It helps the patient. It does various other things. But actually, if you then offer that service at a significant loss, and it's taking up your time and preventing you from seeing other patients, is that the best thing for all of your patients, not just a cohort because somebody else has told you it's a good thing for them? So slight tangent there, but in fact, stuff that I believe you talked about with some of the other members on Ben Gowland's podcast earlier this week. So a bit of a signpost to that.
Okay, this is my favorite one. How much does your heart sink when a patient starts a conversation with, I've just Googled my symptoms?
Not as much as I think other people probably is what I'd say. I think the important thing to remember is that actually patients learning about their health conditions is really useful. And if they've done that, normally you can help them understand the right reasons for things as well. So what I mean by that, if a patient's done a bit of homework, if they've understood some of their symptoms, and they've looked up X, Y, and Z, half the time I'd say the patients have actually got it right, to be honest. And it's important to recognize that there is a good quality of information out there that can help you. Clearly, the issue with some of that is that things like Google and these kind of symptom checker stuff are designed to give you also deflect the risk from the company itself, so that they give you all the options. So inevitably, the big nasty stuff is normally at the top, and the more likely common stuff is right down at the bottom. And common things being common, they're likely to be those. But what I often say to patients is, when they start off with that, I let them talk. And I say to them, okay, so you've told me about these particular symptoms. Actually, you're right, that might be a possibility. And this is what we do to figure that out. But also, what you've explained to me suggests that it might be this to me as well. And I'd like to put things in place so that we're looking at that as well and dealing with that. So then it's trying to help the patient understand that, yeah, some of the stuff they've done has been really useful. And then how can we make that gets us to the right answer? And it's important to remember, sometimes the patients, like I said, 50% of the time they have it right. This helped them understand things. Does it polarize? Yeah, it may do. And like I said, cyberchondria is a growing issue that we're having to deal with. So the concept that the actual worry of what they're looking up online is giving them more health issues and that kind of stuff. But then that can help you direct how you deal with the future consultations as well, I find.
Yeah. Okay. And then the last question that we got from our members was, what do you think is the worth of a PM? And one member went on to expand and say there are occasions where we are aware of practice managers who are paid less than Band 5 or Band 6 practice nurses. And the rationale behind that is because they're told, well, nurses are clinicians. So what's your view on that?
So I think I've kind of answered that earlier with the whole practice manager becoming a partner kind of thing. It's the person and the what the skills they bring to the mix. I think there are various different roles across general practice where the person is worth far more than what the role allows them to do. My practice manager is amazing. Let's be honest. I really would hate to come to work not knowing that she's not going to be there, to be honest. And she's worth everything that we pay her, and probably, to be honest, a lot more. And I would be saying to anybody that if you don't value your practice managers, you've got yourself a real problem, to be honest, because the workload of a practice manager is so complex at times. I know, if we go back a couple of months ago, it was just a nightmare. The number of risk assessments, the number of different things that people were going. I had practice managers, my own practice manager and other areas, practice in my network, literally telling me that they just cannot cope because of the volume of stuff they were getting. Clinicians were complaining about what they were having to deal with. I'll be absolutely, and I was quite clear that our practice managers have it a lot worse. And even went to the system and said, look, you just need to calm down. You need to tone your communication down, and you need to, recognize the fact that you're putting our workforce on the teetering edge. And we talk about the fact there's no GPs. We talk about the fact there's no nurses. Let's be honest, there's no practice managers out there either. So we need to value our practice manager staff significantly in terms of what they can do, because they're often one of a very small list of people that are doing that job and doing it well. I'm going to be slightly fatalistic and suggest I think practice also need to consider what they would do if their practice manager wasn't there. Because let's be honest, if a GP wasn't there, you can often find somebody else to take over that role and deal with the patients and deal with the majority of that. If your practice manager was there, could you honestly say that your practice would still run as smoothly and as effectively, and they're replaceable? And I can guarantee there are going to be practices out there that are thinking, oh my God, I have no idea how to do the payroll. I have no idea how to access our bank accounts. I have no idea how to access QRS, CQRS, or that kind of stuff. And I don't know what the passwords are. I don't know what the logins are. Imagine if that happened, And unfortunately it has. Let's be honest, it has happened in places. So, you're talking about a role that, in my view, is irreplaceable in general practice. I think it's a role that is changing as well. Practice managers are not what they were 10 years ago. They used to simply just be the people that coordinated the members of staff, and now they're accountants, they're HR managers, they're negotiators, they're counsellors. So it's understanding, is that role appropriate? And also, I think practice is now in many places getting to the size where you need to think about the fact it's not in one person's just not enough. Do you need to split it off? I know some practices have done this, have gone down the route of having business managers and practice managers, thinking about that. And particularly, I think, 10 to 15,000 is the sweet spot where you really need to be thinking about that needs to change, because there's just too much work for one person to do. So how's that going to look for practices, and valuing the worth of the PM is absolutely a challenge that is going to grow, I'm afraid. So No easy answers for that one.
No, I know. I came from hospitals, and I found it quite an interesting transition because I came from a big trust where I had a finance department and an IT department and a legal department and a HR department, and then I was all those things when I moved to the side that I'm in. So I think people need to realise that it's a very broad job with a lot of responsibility, and the bigger the practice is, the more support there needs to be in there. I think there are two practices you just have the one person for, like you say, 10 to 15,000 patient surgery. It's just not sustainable in the long run.
And like I said, one thing I would say to any practice manager or any partner watching this right now is, what resilience have you got in place if that person wasn't around tomorrow? You know, how is that practice going to function? Because, you know, the legal responsibilities are still there. You know, how is that going to look? And I know it's slightly fatalistic thinking about that kind of stuff, but it's stuff that if it was to happen, and unfortunately there are places where this has happened, you know, the amount of stress and challenge that's going to cause to everybody involved in that situation is really unpleasant to think about, to be honest.
Yep.
That's a great note to pause on, isn't it? Actually, we've had another question that's come through from the chat. So this, I think, is from James from the Practice Index team itself. If you are watching us live, feel free to ask more questions. We do have a little bit more time if you want. So James has asked this one. Do you want to go for it, Robin?
Yeah, so what can practices do to make GPs enjoy their job again?
Okay, let's be honest. We are 6 months into COVID. It's not a great place right now. Yeah, we're potentially looking at a second surge, and we're being told that certain things are definitely not going the way we would hope. I think hopefully there are some brighter things on the horizon, but it's going to be a challenging few months. I think in terms of making general practice GPs particularly enjoy their job, let's start with that one. First of all, don't work full time. You know, this is the one thing I would say to anybody: do not do full-time face-to-face patient contacts. And the reason why I say that is it's a significantly more complex job than we had 10, 15 years ago, you know, when I first started being a GP 10 years ago. And what it was then is so much different to what it is now. And trying to do that amount of work constantly will just lead to burnout in a really short space of time. So it's having other things that keep you interested and give you the joy of doing general practice. I know many clinicians have obviously over the past few months shifted to doing remote work, and some have found that really enjoyable and, you know, helped them find that their love of general practice again, because it meant that they can spend time with the patients they want to spend time with, and they can, patients that they know they can deal with quickly and effectively, they can do that better in a different way. I also know there are many clinicians out there that cannot stand it, that feel it's just a massive inhibition and really just made their lives so much more complex and brought them more stress and stuff. So then for those people, you know, how is that going to look for you moving forward? Because unfortunately we're stuck with what we've got at least for the next 6 months by the looks of it. How are you going to make that role more effective for you and more safer for you? And it's worth thinking about what that looks, because just carrying on is just going to make you feel even worse. I think for the rest of the team, it's important to remember that we are a team. Absolutely. General practice does not run just because of GPs. General practice does not just run because of practice managers. General practice does not run just because of reception and nurses. It's the team effort that keeps us running, because it's so complex and so challenging, and the demand is so high that you cannot do it all yourself. So work with your team, have a good team around you, and communicate with that team, because you'll often find everyone else has got their own little niggles. But if you find the combined niggles and fix those, that's where life gets a little bit more impactful and a little bit more useful and stuff. And therefore, as a result of that, you know, everybody's life just gets a little bit more easier. And lastly, have some fun. Absolutely. Just, you know, it doesn't have to, everything shouldn't be just about work. Have those daily huddles, have those opportunities where you get together as a team and have a chat and stuff, even if it's via Zoom or Teams or whatever. Just have that contact, and, you know, have something built in within your practice that makes life just that little bit easier. We used to have, you know, the funny word, or, you know, that kind of stuff from everybody on their updates and stuff. And actually, to be honest, I think that's probably something we need to go back to. We need to humanize ourselves within our teams much more than we probably do, and we have to work harder at doing it. Fair enough, but if we can do that, it just makes life so much easier and fun and better. So yeah, how was that?
Yeah, perfect. I think that's the thing, isn't it? We need to remember that we're all people and we've all got stresses and pressures outside of work as well as in work. And if restrictions tighten again over the next few months, we'll be spending more time with our colleagues probably than with our own families. So it's a good idea to just remember that we're all people too, and that we need to communicate and support each other.
Absolutely.
Through it.
Cool. So we don't appear to have any more questions. I hope everyone watching has enjoyed this, kind of live opportunity to grill me and make me squirm a little bit and all that kind of stuff. I've enjoyed it. I love trying to help in these kind of situations and stuff. And I know that we've talked about potentially doing this again. So if you want us to do this again, let us know. Be really keen to hear that. I know that this is going to be shared on the Practice Index forum and stuff, so people can watch this later down the line. And if you have enjoyed it, please let us know. Put some comments down below. Would love to know what you think. Thank you, Robin, for your time. I've enjoyed it. I hope you have.
Brilliant.
And as always, EGP learners, if you want to catch any more of our content, feel free to do so. Practice Index, definitely check them out. They're here to try and help you in terms of how you manage your practice. They've got so many resources on there. Love having a look at their kind of website and the platform that they've got, particularly their social media stuff. I'm a really big fan of that kind of thing. So definitely have a look at that. And I guess, as always, EGP learners is here to help save you and your patients time by taking hands in your primary care and learning.